Okay, in our video series of cardiology lectures, in this video we are going to talk about acute rheumatic fever. We are going to discuss the presentation, the causes, the diagnosis and management of acute rheumatic fever in detail. A 26-year-old lady comes to your clinic complaining of left knee pain. The knee is red, tender and swollen. Patient also complains that she experienced the same pain and swelling in her left elbow 3 days back, but it resolved all by itself. Now the pain is in the left knee. Patient also tells you, the doctor, I have been having these some irregular nodules beneath my elbow. When you examine, you find nodules like these. Patient tells you, the doctor, since yesterday I have been having this type of rash on my back. This is painless and non-pruritic. When you examine the patient on auscultation, you find a murmur. So something is going wrong with the skin, something is going wrong with the joints. There are nodules in the skin, and something is also wrong with the heart. When you take the patient's history, patient tells you that 4 weeks back she developed pharyngitis, but she did not receive medical care, and over a week that patient infection resolved. She thought it's a minor infection and she did not seek any medical care, and after 4 weeks she has developed all these manifestations. This is a classical presentation of acute rheumatic fever. What is acute rheumatic fever? We are going to discuss in detail. Acute rheumatic fever is a delayed inflammatory complication of group A beta hemolytic streptococcal pharyngitis. Patient developed pharyngitis 2 to 4 weeks back that was caused by strep pyogenes, a group A beta hemolytic strep. Then 4 weeks later, patient has this non-pruritic painless rash on the body, a migratory polyarthritis, a arthritis that is migrating from one joint to another large joint. Patient is also having subcutaneous nodules, and patient is also having some problem with the heart. This is a classical presentation of acute rheumatic fever. The clinical manifestations that develop 2 to 4 weeks later can be memorized with the simple mnemonic JOHNS. J for joints, O for myocarditis, O can be remembered as heart, N for nodules, E for erythema marginatum, the rash that patient develops, and S for Sydenham Chorea. We are going to discuss each one of these in detail. Now you would be thinking that why does body develop a delayed inflammatory response against the heart tissue, against the skin, against the joints? Basically what happens is that the strep pyogenes that is causing the pharyngitis, that bacteria has a certain protein called as streptococcal M protein. Immune response forms antibodies against these streptococcal M proteins. These antibodies attack the M protein of these bacteria and they kill the bacteria. But the problem with these antibodies is that these antibodies cross-react. They cross-react with the myocardial proteins like myosin, and they also cross-react with the nerves. They confuse the streptococcal M protein with the normal body proteins. So they are attacking the streptococcal M protein, but they are also attacking the normal body proteins. That is what goes wrong in acute rheumatic fever, where these immune response antibodies are confusing the streptococcal M protein with the myocardial proteins, myosin, and also they are confusing it with certain nerves in the body. Therefore, they are attacking the normal body tissues like heart tissue and nerves. Therefore, these patients develop complications. Therefore, it is very important to treat strep pharyngitis, because if you kill the bacteria with the antibodies, you won't give body enough time to produce these antibodies that are attacking the streptococcal M protein. And when these antibodies won't develop, they will not attack the heart tissue and the nerves. This is the pathophysiology. Everything makes sense when you understand what goes wrong in the body. Now coming to our special mnemonic JOHNS, J for joints. The problem these patients develop in joints is called as migratory polyarthritis. This arthritis, this inflammation of the joints involves all the large joints in the body. It can involve the elbows, the wrists, the knees, the ankles. It does not involve the small joints. It only involves the large joints. And it is a migratory arthritis. Migratory arthritis means, as in our patient that lady presented to us, these patients will develop inflammation and redness of one joint, and that will resolve by itself, and after a few days patient will be having inflammation of another joint. So it will be migrating from one joint to another joint. Therefore, it is called as migratory polyarthritis. This is a classical hallmark of acute rheumatic fever. Now, coming to the complications that occur in the heart manifestations of acute rheumatic fever are called as rheumatic heart disease, and they are very high yield because many times in exams you will be tested on these complications. Heart complications of acute rheumatic fever are the most important ones. They can be divided into two categories: the valvular changes that take place in acute rheumatic fever and the inflammation of the heart wall, that is called as the pancarditis. Now, in the valvular changes, when these antibodies attack the heart valves, they usually affect the high pressure valve like aortic valve or mitral valve, because mitral and aortic valve on the left side and the pressures are higher on the left side. Among the aortic and mitral valve, you must remember that mitral valve is most commonly affected in rheumatic heart disease. So if someone asks you about a single most important valve to remember, you must remember mitral valve being the most important one. Initial changes in the rheumatic heart disease will be different from the later changes. In the initial stages, in the early stages, it will cause mitral regurg and mitral prolapse. In the later stages, it will cause mitral stenosis. I have detailed video on mitral stenosis as well as on mitral regurg. You can check out the link of those videos in my cardiology section. So, in the initial stages, there will be mitral regurg and prolapse, and in the later stages, the valves will get fibrosed, inflamed, then they will stick to each other, and then they will not open properly. That is called as mitral stenosis, where the valves don't open properly. Now, coming to pancarditis, a very lethal and deadly complication of rheumatic heart disease. Pancarditis is dangerous because it causes inflammation. The antibodies attack the heart wall, and they will cause inflammation of all the three layers of the heart tissue. The whole thickness of the heart wall is inflamed. That is called as pancarditis. And remember, it is the most important prognostic factor. If a patient develops pancarditis in the early stages, these patients are at risk of death, because pancarditis can be lethal in acute rheumatic fever. Now, coming to a very important point, if you are a doctor working in USA or UK, many times you would see that immigrants from India, Pakistan, Bangladesh, Vietnam, they would come to you during the pregnancy, and during the pregnancy, all of a sudden these patients start developing shortness of breath and dyspnea. When you keep investigating the cause of dyspnea and shortness of breath and you perform the echocardiography, on echocardiography you see mitral stenosis. These patients were asymptomatic before the pregnancy, but during the pregnancy they became short of breath and dyspneic. Why did they become short of breath and dyspneic during the pregnancy? These patients were having mitral stenosis even before the pregnancy, but they were asymptomatic. But during the pregnancy, they developed shortness of breath. They developed shortness of breath during the pregnancy because in pregnancy, cardiac output demand increases, and their heart is having mitral stenosis for a long period of time. That was asymptomatic. But now in pregnancy, when the cardiac output demand increased, their heart was unable to meet that demand. Therefore, it became symptomatic and the patient developed shortness of breath and dyspnea. Now, a young lady with mitral stenosis immigrated from developing countries. The most common cause is acute rheumatic fever. She might had an acute rheumatic fever in the past that resulted in mitral stenosis, and that mitral stenosis was silent throughout this time. The patient was asymptomatic, but when she developed pregnancy in the later stages, when the cardiac output demand increased, the heart was unable to meet that demand. Many times you will find mitral stenosis incidentally, and the most likely cause is acute rheumatic fever. Valvular lesions may not manifest until pregnancy. On the skin, it can cause subcutaneous nodules like this. Erythema marginatum. Erythema marginatum is a painless, non-pruritic rash that appears on the skin, and it spreads centrifugally, and it has clear margins, very beautiful clear margins with a central clearing. So the central area will be clear and there will be a clear margin outside the rash. That is called as erythema marginatum. Sydenham chorea is a very interesting and diagnostic complication of acute rheumatic fever. It is an involuntary, irregular, non-repetitive movement of the limb, neck, head and face. These patients start developing dance-like movements, and these are non-repetitive movements. Usually the movement disorders that you will see, they will have same repetitive tremors or same repetitive movements, but Sydenham chorea has non-repetitive movements, and these movements will involve whole of the body, and sometimes they can even involve half of the body, that is called as hemichorea, and these movements will be different each time, that is called as Sydenham Chorea, because these are non-repetitive movements. And remember, Sydenham Chorea develops 1 to 8 months later. This is usually more late complication as compared to the heart problems, as compared to the skin problems, polyarthritis and heart problems might appear earlier, but Sydenham Chorea can be months later, like 6 to 8 months later patient can develop Sydenham Chorea, and once it develops, it's diagnostic. And why does it develop? Because the streptococcal M protein antibodies are attacking the nerves of the body, and when the nerves are attacked, they result in Sydenham Chorea. Now, the manifestations, the neurological manifestations that you would see on in the acute rheumatic fever are very interesting. A very interesting complication that you would see in these patients is called as milkmaid grip. Milkmaid grip, the name comes from the maids that milk the cow. The motion that you use to milk the cow is usually like this, where they are holding and then they are slowly releasing, holding and slowly releasing. That is called as milkmaid grip. Now, when you ask these patients of Sydenham Chorea to hold a finger, when you give them your finger and tell them to hold the finger, they will use a motion like this, and they will be continuously trying to hold it, and then all of a sudden, involuntarily, they will lose the control, and then they will hold it again, and then all of a sudden, involuntarily, they lose control and they will do this movement. So this movement appears like someone is milking a cow. Therefore, it is called as a milkmaid grip. When you tell them to grip the finger, they will grip it like this, then they will lose control, they will grip again, they will lose control, they will grip again. This is so interesting. Another feature that you would see in these patients is the Choreic hands. Choreic hands, when movement would appear like if someone is playing piano. There, even you will note their fingers, they will be moving their fingers like this, like if someone is playing piano. Or in some patients, what you would see is that they would flex their wrist and they would extend their fingers and spoon them. That appearance can occur again and again, and that movement is also a Choreic hand. So it can appear as a piano-like movement or a movement like that. Another interesting thing that you would see in these patients is that when you ask these patients to bring their tongue outside and keep it outside, what will happen is that they will bring their tongue outside for some time and then involuntarily they will retract it back. That is called as a darting tongue, where they bring their tongue outside for some time, then it again goes back, then they again try to bring the tongue out, then it again goes back. That is called as darting tongue, the involuntary, irregular movement that is classically seen in Sydenham Chorea. Sydenham Chorea is a dance-like movement. Now, this is a patient of acute rheumatic fever with Sydenham Chorea. Look at the dance-like movement, the irregular movement of the head, neck, body. Look at the chorea in the hands, the abnormal movements in the hand and the whole body. This is Sydenham Chorea. This is another picture showing the dance-like movement, a manifestation, an old picture where they are showing how the patients after pharyngitis develop dance-like movements. So this is the classical feature of acute rheumatic fever. Sydenham Chorea is diagnostic of acute rheumatic fever. Other neurological complaints that these patients might develop is inappropriate laughing, crying, agitation, anxiety, obsessive compulsive disorder. Now, coming to the diagnosis of acute rheumatic fever. In the diagnosis of acute rheumatic fever, we apply a criteria called as Jones criteria. So Jones was the mnemonic that we used to memorize all the signs and symptoms of acute rheumatic fever. And Jones is actually the name of criteria that we will use for the diagnosis of acute rheumatic fever. Now, when you have a patient of acute rheumatic fever, first of all, you try to collect some evidence whether the patient had a group A streptococcal infection. If you find the evidence, that is a very good basis of your diagnosis. What you do is that you take throat cultures, either the patient is having or the patient had an infection, or you test for the antigen of group A strep, or you do antibody test. If the patient had infection 4 to 6 weeks back, that patient will have the antibodies now and you can test the antibodies. Anti-streptolysin O titers is done, and ASO titers, if they are raised, it tells you that patient had a bacterial infection, a strep pyogenes infection. Now, the main thing is you apply the revised Jones criteria. Jones criteria was revised in 2015, and the patients were classified into low risk and high risk based on the presence of carditis. but I will keep it as simple as possible for you. In the Jones criteria, remember there is a major criteria and a minor criteria. Major criteria carries more importance, minor criteria carries a little bit less importance. Major criteria is diagnostic. In the major criteria, we have the same thing, the Jones: migratory polyarthritis, heart involvement carditis, erythema marginatum, Sydenham Chorea, subcut nodules. In the minor criteria, we have arthralgias. Now you would be thinking that there is arthralgia joint related problem in the minor as well as the major criteria. Basically, arthralgia and arthritis are different things. Arthralgia means pain in the joint, while as arthritis means inflammation of the joint. Inflammation of the joint will appear as red, inflamed, tender, swollen joint, while arthralgia means joint pain only. There will be no inflammation of the joint. The joint will not be tender, swollen and red in arthralgia. Presence of fever greater than 38, first degree heart block where you would see PR prolongation, elevated inflammatory markers ESR greater than 60 or CRP is elevated. This comes in the minor criteria. Now, if a patient fulfills two of the major criteria, that patient will be diagnosed as a case of acute rheumatic fever. Or if the patient fulfills one of the major criteria and two of the minor criteria, that patient will also be diagnosed as an acute rheumatic fever. And if a patient was already diagnosed with acute rheumatic fever in the past and that patient has developed recurrent episode, in that cases even three minor criteria are enough to diagnose that patient with acute rheumatic fever. But for now, you must remember at least two major or one major with two minor criteria should be there to diagnose acute rheumatic fever. You must always do cardiac workup whenever you suspect acute rheumatic fever, because pericarditis is the worst complication of acute rheumatic fever. You must do ECG, you must do echocardiography, you must do chest X-ray in these patients. Investigate these patients for any heart-related issues. Even if the first echo is normal and you are suspecting that that patient has acute rheumatic fever, you must do serial echos even if the carditis is not detected early. Now coming to the treatment of acute rheumatic fever. In the treatment of acute rheumatic fever, if the patient is concurrently having group A strep infection, you have to eradicate that by giving penicillin V. Penicillin V is the drug of choice for group A streps. In children, you give 250 mg per orally every 8 to 12 hours. In adults, you give it 500 mg per orally BD. Now in case if the patient is allergic to penicillin, in such cases you can use cephalosporins or macrolides in such patients. Now we will discuss how do you manage each and every complication of acute rheumatic fever. If the patient is having joint pains, you can use NSAIDs, and in adults you can use aspirin. Even in children you can use aspirin, but make sure that the patient is not having any acute viral illness. If the patient is having acute viral illness, then aspirin poses a risk of Reye syndrome. But if the patient is not having any viral illness, then you can use aspirin in children as well. So NSAIDs are preferable. Second line drugs is steroids. Steroids are very important in acute rheumatic fever because steroids will control this immune response. Steroids will stop these antibodies from destroying the body organs, the nerves, the heart, the joints, the skin. In the heart management, if the patient has developed aortic regurg or any regurg symptom, you can use ACE inhibitors, and simply you can go for heart failure treatment. I have discussed the whole management of heart failure in detail in my video on heart failure treatment. You can check out the link of that video in the description below. Steroids can be used in patients having heart complications due to acute rheumatic fever. Now you would be thinking that why are we using steroids again and again? Even in heart failure management secondary to acute rheumatic fever, steroids play a role. Normally in heart failure management, steroids have no role. But this heart failure is due to immune response against the heart tissue. Therefore, in this type of heart failure due to acute rheumatic fever, steroids play an important role. Prednisolone 1 to 2 mg per kg per orally OD is given. Sydenham Chorea, the dance-like movements. This is usually self-limiting condition. All you need to do is wait and watch for some time. Ask the patient to rest. You avoid overstimulation. You avoid turning on extra lights. You reduce the noise. The patient should be in a calm and quiet place, and there should be no overstimulation. It will self-resolve over some time. But if the Sydenham Chorea is severe, in such cases you can use carbamazepine and valproic acid. In the past, haloperidol used to be the drug of choice, but now carbamazepine and valproic acid are preferred over haloperidol for the treatment of Sydenham Chorea. In severe, persistent, refractory cases, you can go for prednisolone or risperidone, an antipsychotic that will reduce the movement. And in severe cases, IVIG and plasmapheresis can be done. In IVIG, antibodies are given, and those antibodies will bind the anti-M protein antibodies, and they will remove those antibodies so that they cannot damage the nerves. In plasmapheresis, what you do is that you take out the patient's plasma and you remove all the anti-M protein antibodies. So in usually it's self-limiting, but in severe cases you can use these drugs. In persistent refractory cases, these things can also be done. Now coming to secondary prevention, remember these patients who have developed acute rheumatic fever episode are at risk of developing further episodes of acute rheumatic fever. Therefore, it is very important that you prevent further episodes of acute rheumatic fever in these patients. It is very important that you promptly treat group A pharyngitis, because their immune system is already sensitized against these bacteria, and it will start producing antibodies if these patients are again exposed to group A strep, like strep pyogenes. If these patients develop pharyngitis, you must treat that, because their immune system is sensitized and will rapidly produce antibodies, and they will again develop more severe complications of acute rheumatic fever. Therefore, it is very important in these patients that you give antibiotic prophylaxis. Monthly dose of IM penicillin G, benzathine penicillin, is given every 4 weeks in these patients. Intramuscular injection of IM penicillin G or benzathine penicillin is given in these patients once every month. Now, if the patient's weight is greater than 27 kg, 1.2 million units of benzathine penicillin is given. If the patient's weight is less than or equal to 27 kg, then 6 lakh units of benzathine penicillin is given. Now you will be thinking, for how long are we going to give these antibiotics? Now, if the patient had rheumatic fever with carditis, with involvement of the heart, but now the patient has recovered and there is no residual heart problem, patient has completely recovered from acute rheumatic fever and there is no residual heart disease. In such patients, if it is an adult, then you can give it for 10 years. Every month that patient will go and get an IM benzathine penicillin for the next 10 years. If it is a child, then until the age of 21, you will have to give 1 injection of IM benzathine penicillin IM monthly. If the patient has rheumatic fever but with carditis, heart involvement, but the problem is that the now patient has recovered, but he has developed permanent valvular defect, patient has developed mitral regurg, or patient has developed mitral prolapse. If the patient has developed a permanent valvular defect, in such cases, this patient is at very high risk that this patient will again develop acute rheumatic problems, infective endocarditis. These patients are at high risk. Therefore, in such patients, 10 years if patient is adult, or until age 40 if the patient is a child, or in some cases even for lifetime, benzathine penicillin is prescribed if there is a high risk. Now you would be thinking that sometimes it can also happen that patient might develop rheumatic fever, but the patient is not having any heart involvement. In such cases, if the patient is adult, then benzathine penicillin is given for 5 years. And if the patient is child, then patient is given benzathine penicillin monthly for until the patient reaches the age of 21. So these are the different cases that you must know about antibiotic prophylaxis. Remember the drug. They should go for regular dental checkups, because if they develop any dental problem, that infection can spread to the heart, and if they have a residual heart problem, any mitral stenosis, these patients are at increased risk of developing infective endocarditis. Prognosis depends on cardiac involvement. As I told you, cardiac involvement determines the prognosis of the patient. Early death is due to myocarditis. This is not due to valvular defects. Early death occurs due to pericarditis in these patients. If you liked my video, please click on the subscribe button and make sure to check out my other lectures on the cardiology. I have detailed lectures on cardiology, neurology, emergency medicine. Make sure to check out my lectures. We talked about what is acute rheumatic fever. We talked about the pathophysiology, antibodies against streptococcal M protein, Jones to remember the symptoms, migratory arthritis, valvular changes involving high pressure valve, pericarditis being the most dangerous one, mitral stenosis being the most common complication, valvular lesion may not manifest until pregnancy, subcut nodules, erythema marginatum, Sydenham Chorea develops late and all different manifestations, dance-like movement, neuropsychiatric problems that can develop. Diagnosis is done with revised Jones criteria, and you also try to find out evidence of group A strep infection. Minor criteria, major criteria, must do cardiac workup in these patients, eradicate group A strep if it is present, must treat the complications of joints, heart, Sydenham Chorea, and Sydenham Chorea mostly resolves within 6 weeks all by itself. Secondary prevention, antibiotic prophylaxis is needed, and the duration of antibiotic prophylaxis. Regular dental checkups should be done. Prognosis depends upon the heart involvement, pericarditis being the most serious complication. If you like my video, please click on the subscribe button and make sure to follow me on Instagram as well as support us on Buy Me a Coffee. Thank you very much.